Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. All right, we're here today with Dr. Peter Rubin, medical oncologist from Southern Maine Healthcare's Cancer Care Center. Dr. Rubin, welcome to the show.
Good morning, Robert. It's great to be here. Thanks for having me.
We usually like to open our show by talking about our guests and how they got drawn to the field of medicine. How did you come to study medicine?
Well, I had a very strong science background as well as a research background, and so it's just one of those things that inspired me to try to combine science of medicine as well as patient care. And so you can certainly do both in medicine, and there's always an incredible spectrum of options when it comes to medicine itself. So from research to administration to obviously taking care of patients. So a lot of opportunities in medicine. You mentioned that there are so many fields that you can go into. Where were you drawn to medical oncology? So again, I was in a research facility doing cancer research and a lot of immunology research, and so I was exposed to patients being treated in this facility at the same time as I was doing research. So I was always inspired by the physicians taking care of cancer patients. When you look after cancer patients, you're really exposed to people who are at their sometimes at their worst, and it's really your job to be able to hopefully lift them up both physically, emotionally, etc. So a lot of challenges, but a lot of benefits. So when you work with cancer patients, what are some of the things that you do that might be different than you would do with other fields of medicine? You know, the interesting thing about oncology is that one of my professors used to say you can teach a monkey to give chemotherapy, but really the challenge in oncology is to really try to decide, what is really motivating a patient to get treated, what are their goals. And we have these conversations a lot, really at every point during their journey with cancer. So you really have to have a sense of trying to determine what is motivating patients, to get treated. Is it really that they want to spend an extra week, an extra month, an extra year with their family? Is it something else? So it's really important to have that kind of relationship. So relationships with cancer patients are by definition typically very deep, and you can't really be very superficial with people. You have to really try to get into their heads and try to figure out what is it that they really want out of this. And it's important that you also impart what are the opportunities for treatment. What does treatment really mean to people? If there's no cure, that treatment is sometimes more supportive, more palliative, and you have to really talk about symptom management with people, which is sometimes really what the goal of therapy is. You've been in the field of medical oncology for quite a while. What kind of things have you seen that give you a good feeling that strides are being made in the treatment of cancer? Well, I think that one of the most important advances has been in supportive care. So, we've gone from seeing a lot of patients who are incredibly ill with treatment to really being very functional. I've seen patients get their chemotherapy and go off to work the same day. So we have great drugs that prevent side effects. So that's really one of the more critical, I think, pieces that we've seen. Then we get into the issues around actual drugs and chemotherapy drugs. So what I think is really critical is really understanding what's driving cancer. So I always like to say that biology is destiny, that if we understand biology of cancer, then the drugs that we can produce and use to treat patients are that much more effective. And there's a lot of examples of that where we've done enough research to identify some critical pieces of cancer cell machinery that we can debilitate, throw a wrench in the works, and it really does incapacitate cancers. Unfortunately, it's not true for a lot of cancers, but we're certainly getting better. And there's examples in treating some leukemia, some types of breast cancer, where when drugs have come on the market, we have literally seen patients who have been on hospice care being taken out of hospice care and have incredibly productive lives afterwards when these drugs have been used. So that's, in my lifetime and in my career, I've seen multiple examples of that. We have a long way to go, but there are advances like that not infrequently. And in the past couple of years, we probably see a new drug being approved by the FDA. If not monthly, probably every other month or sometimes every other week. So, there's no shortage of drugs that are exciting, novel, and hopefully very effective.
I think it's probably safe to say that almost every family in America has been touched in some way by cancer. Would you say that the cancer treatment has become more comfortable to people in terms of what it was 20 years ago and the advances that have been made?
So if by comfortable you mean that the side effects are better managed, I think that's true. So there are some things we can't sometimes help. If hair loss is a concern to someone, I could say that we now have ways of even reducing the severity of hair loss by using something called cold caps. But certainly a lot of the other things, lowering the blood counts, reducing infection risk, reducing the intensity of nausea, vomiting, almost eliminating nausea, vomiting in some cases, has certainly become a reality with some of these drugs. It's really a changed field. And I can even, in my own career, remember a time when I would be seeing patients on a floor, in a cancer floor in a hospital, and walking down the hallway and hearing retching from room to room. And literally within a couple of weeks of some of these new drugs getting approved, you did not hear any retching. It was that dramatic.
Well, one of the things we want to talk about here today is immunotherapy, and I want you to talk a little bit about it. Maybe tell us a little bit about how it came to be, the roots of immunotherapy.
I think it's always been suspected that the immune system had something to do with cancer and how cancer started and how it spread. And there are a number of animal models that were produced where you could take away an animal's immune system and cancer would develop. There are a lot of other examples of patients who were on immunosuppressive drugs for other things like autoimmune diseases, lupus, and rheumatoid arthritis, who may have a higher incidence of certain types of cancers. So we know there's a link. We've always known there's a link. The problem was, how do you manipulate the immune system to fight cancer? That was a bit of a tougher thing to prove and actually take advantage of. So a number of years ago, there's been research in actually taking away, well, let me back up and say this, that we all know that the immune system, there are some fairly delicate regulatory things that happen when you have an immune system. We have to be able to control it, activate it when you need it, but also clamp it down. So the immune system, if you allow it to run rampant, which is an example we see in people with lupus, for example, then you have a lot of organ damage. And so that's an example of the immune system run amok, essentially. On the other hand, if you can somehow control that in a more deliberate way, you can actually activate the immune system by really taking the brakes off it. So there are brakes in place that keeps the immune system from constantly being activated. And there is evidence in the lab that the brakes on the immune system were preventing the immune system from fighting cancer. And so the most important breakthrough that happened was identifying molecules on some of these immune cells that you could block, and by doing so, the immune system could become activated and fight the cancer. So the immune system recognizes cancer as being bad. And our job, or the job of the researchers, was really to identify what is it about these cells that we can block and essentially take the brakes off, which is really the best way to kind of describe what we're doing. We're taking the brakes off the immune system, allowing it to fight the cancer. And so this development was seen with treating melanomas about a number of years ago, where melanoma was always a very difficult type of cancer to treat, and cure was not even a word we used. And then all of a sudden we're seeing, a proportion of people being treated with these drugs actually being cured. Never saw that before. And so this has now been translated into treating other cancers, other solid tumors, such as lung cancer being a good example, some stomach cancers, some other malignancies such as kidney cancers, as well as melanoma. So there are a lot of new drugs. These are the drugs that are being approved frequently nowadays, and they're very effective. We have to change how we look at how patients are being treated. Patients still call these drugs chemotherapy, but they're really not. They're more immunotherapy. They do not have a lot of side effects for the most part, but they can, obviously, people can develop some unusual things like a under-functioning thyroid gland if these drugs happen to cause activation of the immune system to fight the thyroid gland. You can see inflammation of different organs, the bowel causing diarrhea, the liver causing hepatitis, on and on. So I think there's some, different understanding we have to have. We have to also talk to our partners in the primary care field and the emergency departments who see these patients, because they're going to also deal with some of these side effects. So we try to document these things to these other groups of physicians, because they have to be aware of what we're doing, because they see these patients as well. So it's been really a fascinating turn of events where we're still using chemotherapy, and there's now this drive to actually start to combine things. Because one of the things people have noticed is that if you can disable some cancers with standard treatments, radiation and chemotherapy, it generates more debris, if you will, from these cancers. The cancers get chewed up by standard therapy. It can sometimes activate the immune system even more. So these little pieces of cancer cells that have been destroyed by radiation can tickle the immune system, and so by adding these other drugs, you get even a better effect. So we're at a point where we are combining old and new to come up with even better synergies and better combinations. The number of trials that are currently up and running for some of these drugs, numbers in the literally hundreds, if not thousands, across the country.
So essentially, it sounds like with immunotherapy, you're training the immune system to attack itself.
So essentially, the immune system, so cancers have characteristics of the person, in a sense, because the cancer is derived from the person's own genetic material. So they'll have some characteristics, but they also have some unique characteristics. So the immune system can identify those. The problem is that the immune system, the cancers have certain things on their surface that cause the immune system to go to sleep. And so we are trying to wake up the immune system to say, hey, buddy, you got to fight this because it's not your friend. And that's essentially what's going on. It's a fascinating field because, we're not really, when we treat patients, we don't always see dramatic responses. But what we do see, I think, is we see a lot of stabilization. We don't see cancers necessarily getting worse, which really is not a bad thing. If you can freeze things where they're at and allow patients to carry on with their lives, it's sometimes a good trade-off, because ultimately the side effects are not too bad. And the other important thing about these drugs is that the effects sometimes last even after you've stopped the drug. Once you've trained the immune system, is using your phrase, once you've trained the immune system to fight the cancer, you don't necessarily have to keep giving these drugs. The immune system kind of just carries on. So we see these ongoing responses long after the drugs have been stopped. And the real question becomes is, how long do you really use these drugs? What is the right amount of time? Is it a month? Is it 6 months? If you get a response, do you do it forever? Do you stop it? So there's trade-offs, because at the same time you don't want to have patients, attached at the hip to the cancer clinics. You want to give them some freedom and some autonomy. So it's a fun time to do what we're doing, because we're asking questions we don't really have answers for. And this is a field that's evolving really daily. And there's always something new coming out. There's some new side effect we haven't appreciated before that we're trying to put our hands around.
You're listening to Medically Speaking. We're talking with Dr. Peter Rubin, medical oncologist from Southern Maine Healthcare, and we'll be right back with more of our conversation coming up right after this.
Not every boo-boo is an emergency. but it still feels like one. That's why Southern Maine Healthcare offers walk-in care. You'll find compassionate care at wonderfully convenient locations. Open 7 days a week, no appointment necessary. For those times when the unexpected happens, or you're just not feeling great, look for the orange ball as your sign of the best walk-in care. In Kennebunk, Saco, Waterboro, and Sanford, Southern Maine Healthcare, a member of Maine Health.
And we're back with Dr. Peter Rubin, medical oncologist from Southern Maine Healthcare. Now, you said a lot of patients still consider a lot of this chemotherapy. How do you explain the difference with what you're doing?
Well, there's a lot of education. Fortunately, the companies that produce these drugs do a lot of patient-related, have a lot of education material for patients. But it's a ongoing re-education almost on every time we treat people. I think that ultimately people will still call it chemotherapy because that's just a generic term that they use. But I think it's important that the other folks in the system recognize that this is not chemotherapy because, again, the side effects can be different. They can be sometimes devastating because they can also be very acute. If someone has diarrhea, it's not treated the same way as diarrhea related to chemotherapy. And so emergency room doctors can't assume that. They sometimes have to, they usually do have to have a different treatment protocol for treating these patients. So we actually try to go out to the primary care docs and their emergency room docs to really talk about these drugs and how they differ and what the side effects could potentially be. That's the usual way we try to deal with it.
Now, what are some of the side effects for immunotherapy? I mean, they range from things that are mild to severe.
They can be severe, mild, moderate, severe, or devastating. And sometimes, some of these drugs will attack some pretty critical parts of for example, the pituitary gland. There have been, fortunately, very few cases where the pituitary gland, which is the master functioning drug that produces a lot of hormones that keep us alive, essentially, is being attacked, and then all your hormone levels are going a little wacky, and we have to recognize that. It's certainly relatively, I wouldn't say simple to treat, but it's once we recognize it as being a problem, we can supplement with various other drugs. But it's something that has to be recognized, and that's really the challenge, is we have to recognize these things. So the paradigms and how we've been trained and how everyone else has been trained to recognize problems in cancer patients isn't the same. Another good example is lung inflammation that patients can have. They can sometimes come in with shortness of breath and sometimes low-grade fevers, and people assume that it's pneumonia, and sometimes we have to recognize that if it's inflammation, they need steroids, sometimes steroids plus antibiotics, but it's all a matter of recognition. So it's important that patients recognize that. One of the drug companies that produced some of these drugs actually had medical alert bracelets produced for people that had a 1-800 number and that they could call a central office and talk to a nurse who could talk through some of these issues with physicians who may be in very rural parts of the country, which is important because they certainly won't necessarily get exposed, but patients being treated in larger centers getting these drugs. Certainly initially, there was very little information about this, so they had to regulate the whole process and get that information, disseminate it out fairly quickly to people. And so they found different ways of doing that. One was the medical alert bracelets. I don't think we're doing that anymore, but there's more understanding of these drugs. But one good side effect of having these unified medical record systems is that everyone has access to records, so they should know what's going on with people.
Now, from your perspective, when is immunotherapy care indicated for a patient? How does that work?
So that's part of the paradigms and some of the algorithms of how we treat people. Some people, there are techniques that we can test tumors to see if they're more or less likely to respond. So there are actual lab tests where we look at tissue and say this tissue stains a certain way or has some characteristics we think it'll respond. On the other hand, there's not always a correlation between what the tumor looks like or how it responds to the response to treatment. So there are algorithms built, that define and first line treatment of lung cancer, who will get what, or if people can go through chemotherapy and then get these drugs in sort of after they stop responding to something else. I think that one really good benefit of these drugs, if you have patients, and we have a fair number of folks who are a little bit older, who are not great candidates for chemotherapy, but are good candidates for these drugs because of their profile, their toxicity profile is not as severe, we're more than likely to treat them, whereas before we would not have treated them. And we're seeing, I have one patient right now who came in with advanced lung cancer, had a big mass in his neck, and then after a couple of treatments, we can't even find this mass. So there are some fairly dramatic responses. But more than likely and more commonly, what I tend to see is people on these drugs having very stable disease or some minor shrinkage, but at the same time their quality of life is great. They're able to be with their families. They're doing all the holiday stuff. They're not sick, and their disease is controlled. Ultimately, our goal is to treat or turn cancer into a chronic illness. That's really I think the ultimate goal. The cure of cancer is a little more challenging because we're never really going to cure cancer as a whole. We're going to cure specific mutations in cancer. It's not even going to be a matter of curing breast cancer. It's going to be curing a certain type of breast cancer that has a certain characteristic that we have to have a certain drug for. And there's examples of that in other types of cancer where we have a drug or a series of drugs that control a certain type of leukemia, for example, where people are on these drugs for years and their leukemia is controlled. So ultimately, these drugs, I think the potential for these drugs to put the brakes on tumors and keep them from growing and keep them stable and is not unlike how we treat diabetes or high blood pressure. We don't cure these diseases, but we control them. And that's really the goal. If we can do that without a lot of side effects, I'm happy, and I think people are happy.
Now, this sounds pretty complex. Do you watch a patient who's getting immunotherapy? Do you watch them more carefully than you would if they were just getting chemotherapy?
I like to think that we watch all our patients really closely. The frequency of these people being treated varies between every 2 and every 3 weeks. So by definition, they're being watched pretty carefully. Our nurses will typically call patients at home after they've been treated, certainly the first few treatments, to check in with them to see how they're doing. They're given a lot of information, sometimes even more than anyone would like to have, but they certainly have access to that information. And I think we reiterate some common side effects and what to watch for whenever we do see them. And we encourage them to call us or call whoever 24/7. So the issue, I think, is that some of these things are not predictable. Well, they're not predictable, and they're also not predicted based on time. We can't say that the first treatment's going to give us, a side effect 90% of the time if it's going to happen. A lot of these things can happen a year down the road, and so we don't necessarily have a good, we can't anticipate when they're going to happen. We can't see folks on a schedule because we think we know when they're going to have problems.
So at Southern Maine Healthcare, what would you say are some of the cutting-edge treatments that are offered?
Well, I think that, because of our proximity to, major teaching centers in Boston, I think we're obliged to maintain a high profile and a high standard of care, because obviously that's what patients would expect since they live so close and could easily access care in other locations. So I'd like to think that we have as good a program as these other places in terms of accessing state-of-the-art care. The unique thing about Maine is that, for example, right now we have a clinical trial with Jackson Labs called the Maine Cancer Genomics Initiative, where we're going to be analyzing on a genetic basis over 1,000 cancers. I think it's 1,800 cases in the next 2 or 3 years, where patients with advanced cancer can access state-of-the-art, what we call next-generation sequencing, where about 300 different genes will be analyzed to see if there are specific mutations in these cancers that might be driving these tumors. And by doing so, we hope to have access to drugs that in turn might be used or useful in these patients. So that's something that the vast majority of patients in in southern Maine, certainly in the entire state, will have access to. And, it's very promising because I think that this is a very expensive test, and a lot of folks may not have the means to have access to it, but on a clinical trial basis, everyone literally has every opportunity to get involved with the study. And because of the nature of the organization that's doing these testing, it's state of the art. So it's really bringing really excellent high-level care to almost every advanced cancer patient in the state.
For maybe some of our listeners out there who don't know the medical jargon, what is a clinical trial, and how do you recommend somebody to take part in a clinical trial?
A clinical trial is essentially a platform where we can test drugs or a drug protocol in a patient that has some promising characteristics. In other words, a lot of advanced cancer patients we know do not have great outcomes. Standard therapy has limitations, and we want to advance the field. And so the best way to do that is to do clinical trials where we can take a new drug or drug combination, possibly one of these immune drugs, and test and put it into a trial format where patients will either get the novel new treatment versus a group that will get standard of care. And at the end of the day, that's how we advance the field. That's how we know what to do now and in the next 2 or 3 years, and then we move forward from there. So I'm also the principal investigator for all the clinical trials. So my mandate is to bring as many of these trials to trial menu, if you will, that patients will have access to. So in collaboration with what we could now call the Maine Clinical Research Program, we have all their support so we can put these trials into action. Personally, I think that every patient should have access to a clinical trial. They should be encouraged to enroll in clinical trials. It'll benefit patients, it benefits us, it benefits society, if you will. So I'm always a big believer that that's what we should be doing for everyone.
So if patients are interested in learning more about clinical trials, where should they go?
Well, I think that if they're currently in the process of being treated for cancer, I think if there's a trial available to them, then we will hopefully be able to give that information. There are websites. There's a government-sponsored website, clinicaltrials.gov, that will list literally every trial available in the country and where it's located, who's sponsoring it, and who's doing it. So that all that information is available on the internet.
What are some of the most challenging forms of cancer that you come across and that present the most difficulty, the biggest challenges for treatment?
I think that most of the so-called solid tumors are still challenging. If you see cases of any advanced cancer, lung cancer, cancer of the pancreas, cancer of the stomach, cancer of the bowel, all those cancers are challenging. Fortunately, we have options for treatment, and I think what we have seen in the past in terms of longevity, how long patients live with these cancers, has advanced dramatically. So we've doubled or tripled that time frame. Unfortunately, we haven't cured them, and that's how we get into this discussion of how do we keep their disease at bay? What do we do to keep their disease stabilized? And so there are, one of the things we do work with are so-called multidisciplinary teams, where we work with surgeons and radiation oncologists, and we try to figure out what is the best way to deal with someone's cancer. We can treat them with chemotherapy or immunotherapy. Beyond that, can we then introduce surgery to get rid of whatever cancer is left behind? Can we use other techniques, so-called interventional radiology, where radiologists can put probes into different lesions in different locations and do various things to kind of get rid of residual cancer? So we're always trying to look at these things more globally and holistically to kind of figure out what is the best approach. So we don't work in a silo. We work with other people to try to really come up with the best treatment plan for patients.
And one final question here. You've been treating cancer patients for a long time. Is there more hope these days for the cancer patient, more so even, say, than 5 years ago?
I think that there's absolutely no doubt about it. And I think that, and if you look at the graphs put out by various organizations, the American Cancer Society, you look at survival curves of women with advanced breast cancer, the numbers are staggering. I mean, they've literally, in some cases, doubled or tripled over 10, 15, 20 years. And that's certainly true for other cancers. Colorectal cancer is a good example. Historically, the average survival with advanced colorectal cancer was 6 months. It is now approaching 3 years. So, that's just one example, and then we could go on. And melanoma is another. We talked about that earlier. Melanoma, where we're now literally curing sometimes 30% of people with advanced melanoma with some of these drugs, and literally curing because they're living more than 10 years and with no evidence of disease. I mean, this was a fantasy when I was training. I mean, the most depressing thing was seeing advanced melanoma patients or other patients like that because we had no options. We had no great drugs or any drugs. So it's totally changed.
You tuned into Medically Speaking, and we've been talking with Dr. Peter Rubin, a medical oncologist for Southern Maine Healthcare. Well, it's been fascinating talking with you, Dr. Rubin. Thank you very much for coming on the show.
And thank you for having me.
Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities. Brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.